This video is sponsored by the Association of Anaesthetists, A-Line, Health Education Northeast, and NEMO.
I'm going to start off by introducing our keynote speaker, who is Professor Mala Rao. Professor Mala Rao has been awarded an OBE. She's a Senior Clinical Fellow at Imperial College London. She's the Medical Advisor to NHS England's Workforce Race Equality Strategy and co-chair of the NIHR's Race Equality Public Action Group. Her career has spanned public health practice, policy and research. Her past achievements in public health delivery and in workforce development have been groundbreaking in the UK and the global arena. Her research, which has improved healthcare for millions in some of the poorest states in India, resulted in her inclusion among the 100 most influential people in the India-UK relations in 2019. She's campaigned against racism in the NHS throughout her career. Her review of the well-being in Black and minority ethnic populations in England was launched at the House of Lords in 2014 and influenced the establishment of the NHS Workforce Race Equality Strategic Advisory Group, for which she was vice chair during 2016 and 2018. She was co-guest editor of the BMJ Special Issue on Racism in Medicine, published recently in Feb 2020, and is the co-founder of the NHS Race and Health Observatory. She's also included in the top 50 of the most influential BME people in the English Health World, announced by the NHSE Health Services Journal in October 2020. And this one I'm personally applauding. Before it became fashionable, she was already campaigning to address the impacts of climate change on health, especially on women and children. She's also co-editor of the book Health Practitioner's Guide to Climate Change, if anyone's interested in reading. Today, she's going to speak to us about the keynote. She's going to speak to us about the lessons learned from the pandemic. We will now hand the floor to Professor Rao.
Brilliant. Gosh, thank you so much, Sonia, for that very generous description. I thought I was going to, after all that you said, I was going to fail the test to try and upload my slides, and I'm delighted that I didn't. So thank you for that. Well, good afternoon, everyone. I'd like to begin by thanking Dr. Samir Ahmed, Sonia, and the organizers of this event for inviting me to give a talk on COVID and the NHS. And I'm delighted to have this opportunity to share with you my perspectives on why, in that context, equality matters and the crucial role you have in contributing to that goal. But before I begin, I feel I must apologize for some rather crowded slides that I'm about to share with you, but I'm constantly worrying about the internet uncertainties, and I confess I now prepare slides which you can at least read if my audio fails or some such thing, so please do bear with me. Ayat has very eloquently already described the fact that history will remember 2020 as a year when two events collided, resulting in turmoil worldwide, and I'm of course referring to the COVID pandemic and the killing of George Floyd, which resulted in an eruption of anger, pain, and grief, and a massive resurgence of the Black Lives Matter movement. And as countries grapple with the challenges of these two tsunamis and the link between them is beginning to be understood, the world is waking up to the fact that the disproportionate impacts of COVID infection on BME people is explained in substantial part by the racism, discrimination, and socioeconomic inequalities which define their lives long before the pandemic began. But of course, in the UK, we are addressing this against a background of a health and social inequality gap, which is widening substantially. So we're facing the biggest economic downturn in 300 years. People in the most affluent areas are 50% less likely to die of COVID than those in the poorest areas. And we don't highlight this very much, but disabled people have experienced death rates 2 to 3 times higher than non-disabled people. And 1 in 3 18 to 24-year-olds have been either furloughed or have lost their jobs. The share of the working age population receiving universal credit is increasing. And alongside all of that, we have, as of mid-November, tragically seen the deaths of 57,000 people involving COVID. We now know that 80-plus-year-olds with a positive COVID test are 70 times more likely to die. We also know that the risk of dying is higher in males than in females. The people living in more deprived areas have a higher diagnosis and death rates. We also have seen that the greater inequality in death rates compared with in previous years highlights the fact that there is a greater inequality in death rates from COVID than non-COVID causes. Longer term, with the economy being the way it is, we know from estimates that poverty is set to rise, access to food, childhood malnutrition. We might see those sorts of things getting to worrying levels. We may see an increase in damaging health behaviors. And we know from surveys that mental ill health, isolation, loneliness, domestic violence, physical inactivity, and all of these sorts of things are on the rise. And it's against that background that we are seeing ethnic variations and alarming levels of ethnic variations with risks and outcomes from the pandemic. It's already been stated by Ayat and others that people of BAME communities are likely to be at increased risk of acquiring the infection. We know, do we not, from the ICNARC report, the Intensive Care National Audit and Research Centre, as early as in May, that Black and Asian patients were overrepresented among those critically ill with confirmed COVID, receiving advanced respiratory support. And after adjusting for age compared with people from the white ethnic group, look at the risk of death due to COVID in all Black and minority ethnic groups. And here you can see that it's Black African males and females who have the worst risk, with 3.8 times the risk in Black African males. So the ONS, most recent, this is almost hot off the press, this is November update of the ethnic contrasts in deaths involving COVID, concluded with this statement, and I know it's long, but I thought it's an interesting one that I wanted to share with you. Our statistical modeling shows that a large proportion of the difference in the risk of COVID mortality between ethnic groups can be explained by demographic, geographical, and socioeconomic factors such as where you live or the occupation you're in. It also found that although specific pre-existing conditions place people at greater risk of COVID mortality generally, it does not explain the remaining ethnic background differences in mortality. And we now recognize what those additional factors are, do we not, from the Public Health England's Beyond the Data report, which was written after engaging with about 4,000 stakeholders. And it's the stakeholders who pointed to racism and discrimination as being additional factors that needed to be taken into account. Moving forward then, what the stakeholders in the Public Health England review call for is action on the socioeconomic front. Again, Ayat explained these issues brilliantly well, eliminating the income gap, addressing the overcrowding in the housing situation, social support, mitigating occupational risks and exposure, and of course the structural components, tackling racism and discrimination within the health and healthcare system. So of course, if you look at the socioeconomic issues and the occupational issues, some of that, in fact, most of it is in the gift of government and national policy leaders to try and resolve. So where is our collective role? And you can see from this that our role lies with addressing racism in healthcare and in the healthcare workforce. It was Professor Tim Cook, who's a professor of anesthesia, who first published a study which confirmed to us that 95% of doctors and 63% of healthcare workers who died from COVID belonged to a BME background. And the PHE review, again, these are quotes taken directly from there, pointed out that it's historical racism and negative experiences of healthcare, which may have resulted in BME people from the community being less likely to seek care when necessary, and it might explain the disproportionate impacts in the community. But when it comes to NHS staff, perhaps it translates into the same staff being less likely to speak up and demand PPE, even when their lives are at risk. So it seems like a good point to reflect on the first principle of the NHS Constitution. It exists to provide a comprehensive service available to all. It also has a wider social duty to promote equality through the services it provides and to pay particular attention to groups or sections of society where improvements in health and life expectancy are not keeping pace with the rest of the population. And yet, do we do that well? Well, I ask you that question. What do NHS staff surveys show against that context? That there is a consistent reporting of perceptions of discrimination against all protected characteristics, but ethnic background continues to be the most common reason given for discrimination. So if we focus now for a few minutes on the medical workforce, and you have heard extensively during the day on differential attainment. So this is essentially a recap, quick recap of what you already heard. We know that doctors from Black and minority ethnic backgrounds face disadvantage throughout their careers. We know about the differential attainment by ethnicity, which persists across all measures of career progression, entire training pathways, and in medical specialties. A word about international medical graduates who experience the worst levels of disadvantage, being treated at best with indifference and at worst by with contempt, and always being othered, always being perceived as being of lower status or gap filler status, and that evidently that must change. And it's on that sort of basis that collaboration is underway to develop the MRES, the Medical Workforce Race Equality Standard. Odette was talking about the RES. I hope after today, you'll know much more about the MRES and an induction program for international medical graduates as the first priority. You can see from the pictures how many partners have been involved, and I'm absolutely delighted with the level of collaboration this has had. And the Royal College of Anaesthetists has been a leader in that area. So what is the MRES? I'm proud to say it's a world first in monitoring race equality nationally. It is the first step to breaking down structural barriers to race equality. It captures headline data on variations in education and developmental opportunities and performance, career progression, but also the NHS staff survey data extracted for doctor data. So how are doctors perceiving the treatment by patients and employing organizations? The aim is to publish it annually, the data to be collected at national, regional, specialty level, depending on whichever is most appropriate for each indicator, and at a pace best suited to each of the colleges. So what evidence does it draw on? Again, much of this has been said, so I'm going to whiz through this slide. There's an underrepresentation in leadership roles. 17% of medical directors are from BME backgrounds versus 36% of consultants, and almost half of doctors in salaried the salaried hospital grades. BME doctors earn less. Interestingly, Asian males have been more successful at closing that gap, leaving the largest ethnicity pay gap place in the ranking being taken by Black women doctors. We know from RCP data that over 8 years, they have shown that BME doctors apply for more consultant jobs who are less likely to be shortlisted or be offered a post. And in the MRES, we are challenging all of the colleges to produce that same data. the rate, the double the rate of being referred to the GMC. You've also heard about the deferral rates for revalidation, the differential attainment in assessments and exams. There are also reported higher levels of bullying from staff and colleagues, belief that their trust actually cares about their career progression, few opportunities to contribute ideas and make changes at work. And the interesting thing is when you look at the motivation question in the staff survey, BME doctors consistently report higher levels of motivation and engagement at work. A word about medical schools, because, you know, of course, Newcastle and many of the hospitals that you will be working at are part of medical schools. So what's the situation in academia? BME applicants are less likely to be accepted into medical school places, but even so, they make up 41% of medical school entrants. But when you get to professors, it's only about 16%. And the Royal College of Physicians research again highlighted that BME physicians appear to struggle to access research in specific ways because of culture and lack of skills. In all of higher education, BME staff face racism in recruitment, promotion, cultural marginalization, and so on. And the Wellcome Trust, in its response to the Black Lives Matter movement, acknowledged, having hastily, I suppose, done an analysis, that BME and especially Black applicants are less likely to be awarded Wellcome research grants in the UK compared with white applicants. HESA data, this is higher education data, show us that more Black staff across universities are employed as cleaners, porters, or receptionists than lecturers or professors. And what that results in is, you know, this kind of statement, which is so distressing, of Black female academics in a survey saying, "I'm constantly mistaken for the coffee lady." And, you know, since the adoption of the Athena Swan Charter, which was tied to UK medical research funding, so all of our universities had to achieve certain levels of gender diversity if they wanted to get medical research funding, gender has taken precedence in policy making in higher education. But the sad and disappointing fact is that it has benefited white middle class women, but it has left Black and minority ethnic women academics even further behind. I mean, you know, the fact that white colleagues are doing well is something to celebrate, but it's rather sad that BME colleagues are not also doing as well as the white women in academia. What about health and healthcare? Ethnic minority people have a greater burden of ill health. I had the health survey for England as far back as in 2004, this is 16 years ago, showed that the health of white English people aged 61 to 70 is equivalent to Caribbean people in their 40s or 50s, Indians in their 40s, Pakistani origin people in their late 30s, and Bangladeshi people in their late 20s or early 30s. How have we ignored this fact all these years? And we all know, do we not, about ethnic variation in access to healthcare. Maternity, where Black women have 5 times the risk of maternal mortality compared with white women. The mental health issues, again, I have seen reports of this for about 3 decades in our journals. The likelihood of you know, the disproportionate representation, overrepresentation of young Black men in mental health sections and so on, in pain management and in our cardiovascular services, and one can just go on and on. In population research too, many of you are in clinical academic posts. You know, it's an issue to note that there is a general lack of representation of BME people, for example, in research on older populations. And you will all have seen in recent press reports the paucity of BME representation in COVID vaccine research. And now there are new concerns. Algorithmic-based medical innovations such as artificial intelligence, digital health, and so on, are not being developed with appropriate inclusion of the diversity issue. And what that could lead to is a misdiagnosis and underdiagnosis, potentially increasing health inequalities. And the unfortunate thing is research funders and journals have not used their influence as yet to correct that imbalance. So how are we going to achieve equality in a post-COVID NHS? Well, real change is going to require radical, courageous actions with white and BME people working together. I mean, Odette made the point that, you know, the BME staff networks are not exclusively for BME people to join. It's for white and BME people to work together. And it's not enough to denounce racism. We need to be actively anti-racist and inclusive. We could begin by acknowledging that it's racism, not race, because actually biologically we're all the same, is the driver of health inequalities, and that addressing the structural and systemic racism is key. And people with power and influence at this point in time, largely our white colleagues, need to act as our allies. So what are the practical things we could be doing? We could get to know the facts. Please help support the MRES and the data highlighting inequities in your own colleges. And help your colleges to address persistent data gaps. Build more racially concordant strategies for research and clinical care by systematically decolonizing research, teaching, and practice. I'm delighted that it was only yesterday that I discovered that the British Association of Dermatologists is now decolonizing its pictures by including skin of color in all of its teaching and its resources. Isn't that a nice thing to hear? So a shout out for that and its vice president who gave me that fact. Challenge the inequalities in differential attainment. Why is it that there is a dearth of BME faculty? Why are there low grant funding success rates? And we need to start challenging even organizations like the Wellcome Trust about these sorts of figures. Sonia rightly mentioned that I'm something of a climate activist, and so I can never resist the temptation to talk about climate wherever I go. But actually, this isn't something, that's a complete aside. There is a connection. While racism is a public health emergency, the climate emergency is our biggest global public health threat. The 2030 is the deadline for halving global CO2 emissions is only 9 years away. And isn't it exciting that Sir Simon Stevens only recently published the Delivering a Net Zero NHS report and is leading the ambition to become, for the NHS to become the world's first carbon neutral national health service by 2040. And we've all seen this pause in normal working patterns, which has led us to think the unthinkable and re-evaluate alternative ways of working and living, and air pollution is improving. But in all of this, the BME voice is so muted, and yet many of us, even second generation people, do take an interest in our mostly developing country origins, where these are real issues that our colleagues and families are facing today. So my challenge is that I believe that we BME people should be leading the way on climate action in the NHS. So in conclusion, people might say, well, does any of this matter? There isn't just a moral justification for race equality. There is plenty of business evidence too. And I think Professor Namita Kumar was talking about some of it. The evidence of the NHS staff surveys demonstrates that the extent to which an organization values its minority staff is a good barometer of how well patients are likely to feel cared for. Now that's important. There is even more compelling evidence from industry. McKinsey's series of 3 studies in 2014, 18, and 2020 across 15 countries assessing the business case for diversity demonstrated its link with profitability, with a higher likelihood of outperformance with ethnic diversity, interestingly, than even in gender diversity. So I'll conclude, ladies and gentlemen, by saying we all have a duty, but also the power and influence in our own spheres of influence to act on racism, and, as in the words of the Reverend Al Sharpton, to help turn this moment into a movement. So thank you so much for listening.